So I've been tasked with teaching you a little bit about what the indications are for bariatric surgery in adolescents, or in children, rather, to be more precise. And I'm going to give you a little historical background and kind of show you where we are, maybe challenge you a little bit on the ethical fronts as well, so that we always keep that a little bit on the table. So the dates, as Janie pointed out to me, are not exactly precise, but more or less this is the timeline, starting in the 1950s with the development of weight loss surgery. And what we're really going to talk about today are these blue arrows, which are when did we start talking about indications for adolescents, and what were they? And this actually started in 1991 with the NIH consensus statement, which I'm sure you all are very familiar with, that said in adults, BMI greater than 40 or greater than 35 with comorbidities. That's where we started. But they specifically said that children and adolescents have not been sufficiently studied to allow a recommendation for surgery for them, even in the face of obesity associated with a BMI over 40. The reason, and it's pretty intuitive, is that in discussing the risk of surgery versus the risk of not doing surgery, which is always what we do as surgeons, we didn't know. We didn't know what would happen in terms of complications to growth and development in this population. We also knew, and it has been borne out, that there probably was a big benefit in doing this earlier for children in terms of their comorbidities. So it really was an unknown equation at this point. That led to development of teen labs under the direction of Tom Inge and a lot of research. Tom and I and several that are here were part of this initial paper in 2004 in response to what we were seeing in our practice, which were really young children, sometimes going to other countries, sometimes being done in our cities, who were undergoing these major surgeries without knowing what the complications would be. And so we developed this initial statement, Concerns and Recommendations, in 2004, that basically was a very high bar. It was, we don't really know what's going to happen, so we want to be very, very certain that we're not going to hurt children. So the big point here, and you'll see a lot of this repeated in the recommendations and the criteria, that we set this extraordinarily high. We said that they had to be over 40 BMI with serious related comorbidities, or have a BMI greater than 50 with less severe comorbidities. So everybody had to have comorbidities, and it was the highest bar that's ever been set. That was 2004. As more data came in, Dr. Pratt then developed this new set of guidelines in 2009, which basically said that a BMI greater than 35 with serious comorbidities, so this is diabetes, moderate or severe obstructive sleep apnea, pseudotumor cerebri, and severe steatohepatitis, was really the criteria for children, and greater than 40 with mild comorbidities. And then we still don't know what's going to happen. So Tanner stage, and by the way, for those of you taking pictures, please feel free to tweet, whatever you want to do. I'm happy to provide this URL so you can have the whole presentation. So no problem, you can email me after, I'll get it to you. But for these, what we were really concerned about and kept talking about was, we don't know what's going to happen if we operate too early. So we set Tanner stages of 4 or 5, so almost completely through adolescence, skeletal maturity, and then all of the psychosocial things that go with dealing with teenagers. So they have to have a stable environment, they have to understand, they ethically have to give assent. All of that was put into the criteria. Mark Mikulski with ASMBS then did the first set of ASMBS guidelines, which again reiterated, greater than 35 with major comorbidities, greater than 40 with others. Recently, from France, this is a really beautiful paper, I think. Unlike in the United States, they really are able to have the data for the entire country. And they really reviewed what was going on in France and what the criteria should be. This bar, as you'll see, is going to be moving up and down on when do we operate and what are the criteria. What they said in this paper, this will look familiar, greater than 35 BMI with a severe comorbidity, greater than 40 with a moderate comorbidity, within the framework of a regular multidisciplinary treatment program. That's in all of the criteria, but they say for at least 12 months, which is the longest that you'll see anywhere. And then thorough monitoring of the adolescent to make sure they'll comply and that this will work. They also insist on weight stabilization. So most people who do adolescents don't require weight loss. I know in our programs it's not a spoken protocol rule, but we're always very interested when they stabilize their weight. That's a very good sign. They insist on it. Also the Tanner stage, the ability to follow the changes, and the family, again, being a supportive environment that understands and can comply. They do not recommend it in decompensated or untreated psychiatric disorders, syndromic obesity with severe mental retardation, obviously a pregnancy is being planned, or in anyone under age 13. Now, most recently, and this is so hot off the press that I don't have the, couldn't get to the PDF because I didn't want to buy it from ASMBS, but this literally came out this week, all right? Now, you're going to see this bar, again, moving, all right? And what Dr. Pratt has done with the ASMBS group is change this again and liberalize it. So this is the most current recommendation from ASMBS, that we can perform bariatric surgery in children who are 120% of the 95th percentile. That's a BMI of 35, basically. So pediatricians speak in the 95th percentile, so that's why this is phrased this way, with any comorbidity, or BMI of 40 without a comorbidity. They state that they don't really believe Tanner stage is a concern, and not that we should be doing surgery on 10-year-olds, but that they should be referred to a program. This is, again, addressed a lot to the pediatricians, to be evaluated and put into a system where they can be evaluated and appropriate decisions made about their surgery. And there's a lot less concern in these recommendations about developmental delay, syndromic obesity, and autism. So we went from extremely nervous high bar to more liberalized. The French have gone back up a little bit, and now ASMBS has us down here. What do you make of that, and what do you do in your own practice? Or more importantly, what do I think we're going to be seeing in the future? What is the next set of criteria going to be? It still goes back to this. We still do not understand what's going to happen 20 years after operating on a 14-year-old. Okay? We're in the process of collecting that data, but it's very, very important to realize we still don't know that. We do know that there's a huge benefit to intervening early, particularly in the severe comorbidities. We know that it improves quality of life. But this side of the equation is still a little bit unknown. And we have to have a little humility, because if you look at that timeline again, the things in red are no longer done. The things in yellow, the open Roux-en-Y gastric bypass, some of the duodenal switches, the adjustable gastric band are in yellow because there's a lot of concerns. And you can see the timeline that what we're doing as surgeons and what we're doing in metabolic surgery is taking the best choice we have at the moment to treat this severe disease of obesity. But we cannot lose track of the sight that this is an ongoing process that we have to think about. This is the paper written in 1983 that was the final nail in the coffin for the jejunal-ileal bypass. That operation was performed from the time it was developed in the 1950s all the way up through 1990 in some places, if you believe it or not. Very dangerous operation. We all know that's absolutely not to be performed. But there were at least 100,000 patients who underwent this operation, and some of them after all the data was known. So we have to have a little bit of humility about the evolution of these operations. This was presented yesterday. I really apologize if you're the one who presented it that I didn't write down the name. But we all know the band is decreasing dramatically. Sleeve is going up. We see a change in what we're performing in terms of operations, and you'll hear more data about that. And here's the crux, right? A 15-year-old who gets weight loss surgery today has a predicted lifespan of 75 years, which means when we do these operations, we're talking about a warranty, in quotes, of 60 years. This is a very different ethical paradigm than if you're operating on someone who's 50 or 60 years old. It boils down to the ethical principles: first, do no harm, and do what's right. That balance again. And Dr. Pratt said it beautifully in her paper in 2009. All programs performing weight loss surgery in adolescents should participate in rigorous long-term data collection to improve the evidence base in this field. And I will tell you right now, and I will just bring the elephant out, you will never be paid for this. You will never be paid for this. But it is our moral and ethical obligation, if you're going to operate on adolescents, that we do absolutely our best job at trying to get every bit of data we can for 10 years, for 20 years. It's not acceptable that we report 30-day outcomes and 1-year weight loss for adolescents undergoing this surgery. So as you're thinking about this, think about what you would do to try to ensure having that data to know how your patients do and to contribute to our overall understanding of these operations. So when I put together all of the previous until this recent one, where we really are up until this week, okay, is in adolescents greater than 40 BMI with major comorbidities, greater than 35 with minor. Tanner stage 4 or 5, which is about 13-year-olds in girls and 15 in boys. They must have a stable, supportive family. This is not something a teenager can do on their own. They must be in a multidisciplinary program with pediatric specialists for a period of time, whether that's 6 months, 9 months, 12 months, and they must demonstrate, the family and the child, understanding, compliance, and the child must assent as well as the parents consenting. We can't treat. The contraindications are untreated or uncontrolled psychiatry issues and no planned pregnancy for a year or two. We also must study long-term outcomes. We have to each individually figure out how we're going to collect that data, and we must alter or change procedures based on the evidence. We will have more information about which subgroup of patients need which operation. And it's not going to be acceptable that we only do one kind of operation and that's what we offer. So thank you very much for attention. And I don't know, are we going to do questions after each one or?
Questions at the end.
At the end,
We're going to hold questions till the end.
So
we'll bring everybody up and have a panel.
write down questions and then we'll go from there. Thank you very much.